Good morning. Welcome to the KHC monthly webinar brought to you by your friends and colleagues at the Kansas Healthcare Collaborative and in partnership with the Kansas Medical Society and Kansas Hospital Association. Today is Wednesday, August 26, 2020. My name is Michelle Clark, a program director for KHC, and I will serve as your facilitator today. The session is being recorded and will be available on our website in the next day or two. We are glad you could join us this morning as we learn together about the CMS Appropriate Use Criteria Program, the basics and beyond. If this is your first time to join us in the GoToWebinar platform, we invite you to become familiar with the attendee control panel. The handouts for today's presentation are available in the handout section. Be sure to access the presentation handout and the CDS overview that are available there. We also invite you to submit any questions or comments for the speakers in the questions pod. We will pause briefly between speakers, and if we run out of time to get to them all, we will be sure to respond in a follow-up communication. And here's our agenda. Following our featured topic, we will wrap up with additional resources. We also ask that you take a moment to our post-event, to take our post-event feedback survey. We ask that you be ready for polling questions as well. We have 3 polls at the beginning and 2 more sprinkled throughout the hour. We are very pleased to introduce our special guests. From the American College of Radiology, we have with us today Kathryn Keysor, Senior Director of Economic Health Policy, and Christine Waldrip, Director of Appropriateness Criteria. We also give a warm welcome to Dr. Louis Capponi, Vice President and Chief Medical Informatics Officer at SCL Health. Dr. Capponi will anchor our speaker lineup to provide a field perspective for implementing the CMS AUC program. We also want to give a shout out to Nancy Fredericks, American College of Radiology Senior Advisor for Quality Programs, and her team, as well as Jill Doherty of the KHC staff. Their wonderful coordination and assistance were so helpful in making today's presentation possible. 2 other KHC staff members I would like to introduce are Phil Coffin, Director of Communications, and Rhonda Lassiter, Office Manager, Executive Assistant. They are on the line with us to help facilitate our polling questions and answers, and anything else that we may need. So let's get started. So let's hear from you and who is in our virtual meeting room with us. Phil, will you open our first poll? And please take a moment to let us know where you are joining us from. A hospital, a clinic or other ambulatory setting, or maybe a partner organization or other organization. And since we'll be pausing from time to time for polls, we appreciate your speedy responses. All right, Phil, let's close the poll. And if you will summarize our responses.
Sure. We had 69% from hospitals, 17% from clinic or other ambulatory setting, 8% from partner organizations, and 8% other.
Okay, awesome. Thank you. And thank you, and welcome to our monthly KHC virtual event. We will now move straight into our featured presentation, Preparing for the CMS Appropriate Use Criteria Program, the Basics and Beyond, brought to you in partnership with the American College of Radiology. This is a timely topic and one with broad interest across the state and nation, and we're pleased to bring this valuable information to you. But before we hand it over to our first presenter, we have 2 polling questions for you. Everyone ready? All right, Phil, will you open polling question number 2, please? This question asks the audience, how would you describe your familiarity with the CMS Appropriate Use Criteria Program? Are you familiar with the name but not program specifics, unfamiliar, somewhat familiar, or very familiar? Please make the best selection for you as we begin the program. And then Phil, whenever you're ready, please close the poll and let's see what our responses are.
Looks like we have 14% familiar with the name, 49% unfamiliar, 35% somewhat familiar, and 3% very familiar.
Great. All right. Thank you. All right. One more polling question. So Phil, let's go ahead and open this one. How would you describe your hospital's or clinic's level of readiness for the start of the CMS AUC program? Have not started, getting ready, such as collecting information and reviewing tools, almost ready, where you're at the point you're implementing tools, training, and testing, or are you ready? If you're not sure, just let us know that. And so please make the best selection for this question. And Phil, when you're ready, please close the poll and let's review our responses.
We have 27% have not started, 22 getting ready, 5% almost ready, 5% ready, and 41% unsure.
Okay, well, very good. Thank you, everyone. So I will now turn the program over to our first presenter, Katie Keysor. And Katie, the floor is all yours.
Thank you very much, Michelle. Can we have the first slide? Okay. So based on the poll, I think this is a very timely presentation for you all to kind of get the basics of the Appropriate Use Criteria program mandated by PAMA. So I think the first question a lot of folks ask is, how do we get here? Why clinical decision support? Why this mandate? And I think, you know, everyone recognized the need to control inappropriate imaging. It was certainly brought up by MedPAC, the Medicare Payment Advisory Commission, and others as well. CMS has been considering pre-authorization for imaging services for many years. It was in even President Obama's budget. It's been in President Trump's budget. So it's something that has been considered for quite some time. And based on our experiences with private payers, prior authorization can be a very cumbersome process and time consuming. And so the ACR looked to the resources and the tools that we have to try to come up with an alternative, and clinical decision support is the alternative that we presented. Next slide, please. This is just a list of acronyms. I won't go over them all, but I'll try not to speak in too many acronyms. I think the ones you'll hear me say most frequently are AUC, for Appropriate Use Criteria, and Christine will go into details on that in her presentation on exactly what constitutes the Appropriate Use Criteria and how they're developed. The other acronym that you'll hear me say a lot is Clinical Decision Support, so CDS. Next slide, please. So what are the goals for the AUC policy? Well, it's really a quality program, and it's a program that's aimed to move towards value-based care. These appropriate use criteria, as Christine will explain later on, are very evidence-based documents, and this is a point of care alternative to prior authorization. So this is at the moment that the referring physician is ordering the imaging test, you will get feedback on the appropriateness of that study. The AUC program also protects patients from unnecessary procedures and radiation, and it really promotes care coordination. If you get a response from the clinical decision support system that indicates that it may not be the best imaging test for that patient at that time, you can certainly call the radiologist and have a discussion about what might be the most appropriate test. Next slide, please. So the basics of the program, and it sounds like a lot of you are not familiar, so I do want to go over this. The ordering provider must consult, but not necessarily adhere to, appropriate use criteria for Medicare Part B advanced diagnostic imaging services. So that includes CT, MR, PET, and nuclear medicine services. The not necessarily adhere to point is what distinguishes this between prior authorization. Prior authorization by private payers means you either get approval or you don't. If you don't get approval, you cannot move forward with the service. The consultation in this program is just feedback. So if you get kind of a red score or a not appropriate score, that does not mean that you can't move forward with the test. It just means that perhaps you should consider an alternative. If, you know, depending on that patient's particular circumstance, you could move forward with the study even if you get a red score. Now, the other thing I want to point out here is that this is not tied to coverage. This is a quality program, not a coverage program. So no matter what the result is, you want to make sure that you're still looking at your local coverage determinations and national coverage determinations to determine whether the service will be covered. And that's a separate issue. So the furnishing providers of advanced imaging must document each consultation on the CMS claim. So the furnishing providers are the ones that perform the imaging service. And they have to, when they're submitting the claim for the service that they performed, they need to include the unique clinical decision support mechanism vendor G code. So every mechanism has its own G code, and you would use that code. The CMS, and then there's a CMS specified modifier related to the consultation results, or if there's an applicable exception, and I'll go into those a little bit later. Providers can access the imaging AUC by a qualified mechanism that's either integrated into a health record system or a standalone qualified mechanism that's available via the web. In the future, so right now the penalties here are if the furnishing provider, if the radiology provider does not include the information on the claim, that claim will be denied. Not right now. Right now we're in educational operations testing period, and I'll go into the timeline in a little bit. But moving forward, the penalties will be that the imaging provider will not be paid if that information is not on the claim. For referring physicians, if you have a referring physician who is consistently ordering against the appropriate use criteria, they will be subject in the future to an outlier program and perhaps prior authorization for the services that they are not consistently adhering to the results. Next slide, please. So again, the CMS rules for the AUC program, there must be at least one qualified clinical decision support mechanism that offers a no-cost web-based portal. There's currently three free options, and those are listed on the CMS website. There's currently a total of 20 qualified mechanisms that are available, and the choice of which mechanism to use really depends on the services that you provide. So you'll want to look at the mechanisms to see what appropriate use criteria they have in their systems to make sure that it's ones that you need. If you order a lot of cardiology tests, then you want to make sure that the mechanism you use has a lot of cardiology appropriate use criteria integrated into it. The tool must provide immediate feedback to the ordering professional. So this is not where you have to get on the phone with somebody and get a pre-authorization. That might take a while. This is immediate feedback. Next slide, please. The exceptions. There are exceptions to this policy. The emergency departments in general are not exempt from the program. However, emergency services as defined by EMTALA are exempt. Inpatient studies are exempt. Critical access hospitals are exempt. And this includes the professional component, the reading of the study that's performed in the critical access hospital. That's one of those outstanding questions that we have from CMS of how a professional component claim for a service provided in the critical access hospital would be identified, so that it's identified as an exception, but it is, CMS has made clear that any study performed in a critical access hospital is exempt on both the professional and technical component sides. The ordering professional may experience a significant hardship, and that's things like insufficient internet access in very rural areas, electronic medical records, or clinical decision support mechanism issues, and then extreme and uncontrollable circumstances that includes natural and man-made disasters. Next slide, please. This is the original timeline that was included in the PAMA legislation. As you can see, initially the consultation was supposed to be required on January 1st, 2017, with outliers identified January 1st, 2020. Next slide, please. This is the updated timeline. The program has experienced several delays. 2020 began, January 1st of this year, began an educational and operations testing period that was supposed to last for 1 year. We were expecting to hear in this year's Medicare Physician Fee Schedule proposed rule whether it would move forward in 2021. It was not mentioned in the rule. However, CMS did post on their website just a couple of weeks ago that the educational operations testing period would continue through the end of 2021. So right now, January 2022 is the earliest that you would see any penalties, and 2024, 2025 is the earliest where we would see outlier identification. Next slide, please. CMS has a great website with lots of information. Here, this is a link to that. Just want to, I'm sure you'll have access to the slides after the presentation. Oh, next slide, please. Recent program update, as I mentioned, there was nothing about the program in the 2021 Medicare Physician Fee Schedule Post rule, but they did include an update on their website. And then these are links to additional resources with the specific claims guidance on the CMS website. Next slide, please. The priority clinical areas are what will be used to determine the outliers. Won't go into detail on this, though they will be future rulemaking before the specifics of the outlier program are identified. But it is important to note that when the program is fully implemented, the consultation is required for all advanced diagnostic imaging services, not just those within these priority clinical areas. Next slide, please. Again, outliers will be subject to prior authorization, and there will be additional rulemaking on that in the future. Next slide, please. The educational operation testing period, honestly, at this point, nothing is required to be included on the claims, but CMS did indicate that they expect the consultations to be taking place, and we encourage people to really practice right now so that we can work out any bugs in the system right now. Next slide, please. Claims processing requirements. There's 3 pieces of information that must go on the claim. That's the NPI of the ordering professional, the G code for the mechanism, and the modifiers, which I discussed, but we'll go into a little bit more detail. Next slide, please. These are the modifiers for the hardship exceptions. I won't read them off to you, but there are modifiers for each of them. Next slide, please. There are 3 modifiers to report adherence, so you can either report adheres to the mechanism, does not adhere, or if the result is that there is not an appropriate corresponding appropriate use criteria in the mechanism, you'll get there's a modifier for that as well. Next slide, please. And then this is an unknown modifier, so that's something that could be reported right now. If you just want to get into the habit of reporting something on the claim, you can use this MH modifier just to say, hey, I know this is a requirement, but I don't have any information from the referring physician. Next slide, please. So right now, I would encourage all of you to meet with those in charge of implementation within your institutions, find out if there's a plan for educating referring providers. The ACR has a lot of resources for referring physician education. I'd be happy to help you with that if you want to reach out to me via the email address at the end of the slide deck, and work with your institution to determine what you will do in the event that there's referrers who are not complying with the requirements and how to handle that. And I would encourage you to check the CMS website for additional guidance. It's a really great website, not too much information, just enough, and a lot of details as to how this is moving forward. Next slide, please. And with that, I'll take any questions that you may have.
Great. Thank you so much, Katie. And this is Michelle. Rhonda, do we have any questions or comments in the queue for Katie?
We do have one, Michelle. This is from Jill. Jill is asking, can you explain how the ordering physician would be looked at when the RHC is owned by a CAH? For example, would the RHC employ physician who is seeing the patient in the clinic, POS, be exempt from AUC because the RHC is owned by a CAH?
I'm not completely familiar with the semantics of all of this, but I think the answer that CMS has been providing is that it determines the setting is where the actual imaging exam takes place. So I'm a little bit unclear as to the ownership issues that's within the question here. But if the imaging takes place in the critical access hospital setting, then it is exempt. It doesn't matter where the ordering physician is, and if the ordering physician is within a critical access hospital or not, it's where the imaging service is performed. I hope that answers your question. If it does not, please email that address there and I will find a more specific answer for you.
Thank you very much, Katie. And I will go ahead and move on to the next segment and our next polling question. So Phil, will you please open polling question number 4? The question is this: to what extent is ordering imaging exams based on evidence-based guidelines emphasized at your facility? This is a high priority. The topic is frequently emphasized at meetings and through the organization's communication channels. Teams are currently engaged in quality improvement initiatives about evidence-based imaging care, or somewhat of a priority. The topic is occasionally emphasized at meetings and through the organization's communications channels. From time to time, teams are engaged in QI initiatives about evidence-based imaging care, or it's not a priority. The topic is not often emphasized at meetings and through the organization's communication channels. Teams rarely engaged in QI initiatives about evidence-based imaging care, or don't really have enough information to respond. So, Phil, whenever it looks like a good time, would you please close the poll and summarize the responses for us?
Sure. So we have just 3% high priority, 24% somewhat priority, 15% not a priority, and 58% responded that they don't have enough information to respond.
Okay, very good. Thank you very much. All right, moving along now, we will turn the program over to Christine Waldrip. Christine.
Hi, thanks for the opportunity to speak with you today. I am the director of the ACR Appropriateness Criteria program at the American College of Radiology. So I'll be spending some time today just speaking with you a little bit about our specific AUC, which are called the Appropriateness Criteria. Next slide, please. So these are the objectives of today, just again to provide you with an overview of our development process and our methodology. Also to explain how you can access the Appropriateness Criteria documents and how you can provide feedback on them, and describe briefly how they're used in clinical decision support. Next slide, please. This slide just describes at a very high level what the ACR AC documents are. They are evidence-based guidelines. They're really intended for the referring physicians and ordering providers to provide guidance on ordering the most appropriate imaging exams for specific clinical conditions. And as we mentioned earlier, as Katie alluded to, the CMS terminology for this are AUC, or Appropriate Use Criteria. Next slide, please. So the AC program has been around for over 25 years. We're really proud of that. It started back in 1993 was when the first groups were formed to work on this guidance, and the first AC documents were published in 1995. We have over 26 expert panels in diagnostic imaging and interventional radiology that prepare and create the guidance documents. They all are multidisciplinary groups, which I'll go into that a little bit more in a subsequent slide. We've got over 190 documents with over 1,600 clinical scenarios addressed in all of our guidance. We've got a number of new topics that are in development. Those new topics are often based upon the feedback that we receive from users and those that access the documents. And really the AC are widely considered the most comprehensive imaging guidance available. Next slide, please. This slide here is just trying to reinforce the evidence-based nature of our process. We do follow a rigorous methodology in the development of our guidance documents. We have the ACR staff that support the effort and work with our expert physicians. They have advanced degrees in public health or a related discipline. And as I said earlier, we've got expert panels comprised of physicians who are the clinical experts in these particular areas. We conduct literature searches to identify the most relevant and recent literature to be used in the recommendations. If the evidence is lacking, expert consensus or expert opinion may be used. The evidence is summarized in the evidence tables using a methodology that's developed by our methodology subcommittee. We also have something that we call the strength of evidence, which is a roll-up of the evidence for each of the individual recommendations. The process that we use to determine the recommendations is based on the RAND UCLA appropriateness method. We do review all of the documents annually to determine if there's any really new or important evidence out there that would change the recommendations. So these are all just really speaking to, again, the rigorous methodology that we've employed to develop the guidance documents. We currently have over 600 total participants in creating those documents. It's comprised of both radiology experts and clinicians. And there are clinicians right now currently who work with over 40 different societies to recruit experts in from both the specialist side and also primary care physicians. So the summary of this slide is that we have a very transparent and reproducible methodology for the creation of our AC documents. Next slide, please. This is a sample of one of our variant tables, and the variant is really just a clinical scenario. So this is for our seizures and epilepsy document. And just to give you a sense of what these look like, so the variant description there, the new onset seizure not related to trauma, that's the clinical scenario. Then we list the potential procedures that may be considered in the evaluation of the patient in that clinical scenario. Our panelists go through a process to come up with an appropriateness category or recommendation. You can see there are three different appropriateness categories: the usually appropriate, maybe appropriate, or usually not appropriate. And then we also include a relative radiation level for all of our diagnostic exams. And that relative radiation level is a population-based radiation dose estimate. We have a group of expert physicists and physicians that derive this based on the literature. Next slide, please. So the next few slides, I'm going to focus a little bit about on how you can access the documents. So all of the documents can be accessed on our AC website. Anybody with internet access can get to them. You don't have to be an ACR member or have a specific login. You can get to this site if you have internet access. So we are trying to make it easily accessible to people. There are currently two ways that you can access the documents. There's a browse topics feature, which just lists each of the individual documents. And then there's a search feature, which allows you to do a little bit more filtering and advanced searching. And this is also a mobile-friendly version. The search version of it is. A login is required for the search feature. There's just a few questions associated with that, but it's not a cumbersome process at all to get to that search topics feature. We also do include a number of supporting documents on the site that describe the methodology, the list of societies we participate with, and just other relevant documents related to the program. Next slide, please. This just shows you, this is a picture of the Browse Topics feature to give you an idea of the different documents that are available. So for each of the guidance documents that we prepared, there's a narrative and a rating table. That rating table is the variant table that I showed you before. And it really can range from anywhere from 1 to some of the documents have 10 or 11 different variant tables in them. The narrative is the summary of the literature related to that particular condition. And the evidence table, which I alluded to before, which is a summary and evaluation of the evidence, all of the references included in the document. Then we have the literature search, which describes the search strategy that was used, as well as exclusion and exclusion criteria for that literature search. And then there is an appendix document, which includes the strength of evidence, as well as a little more detailed information on the ratings process and how the panel members' ratings came out for the evaluation of those recommendations. We're also really proud to talk about the patient summaries. We don't have those available for all of our topics yet, but we have over 50 of them that have been prepared. And those patient summaries are documents, short documents written by patients that summarize the AC recommendations in really easy, simple to understand language. So all of this, again, is available for anybody to access at any time. Next slide, please. We also have a feedback site, and this is an opportunity for anybody that would like to comment on the AC content to provide your feedback. We take good comments, we take bad comments, anything that you would like to comment on the documents, we're happy to look at that, then we track that and manage it, and we'll share it with our expert panel members when we receive it. Next slide, please. So transitioning a little bit into how the AUC are used in CDS. The ACR was named a Qualified Provide Letter Entity, QPLE, in 2016 by CMS. And this meant that our AUC could be consulted to fulfill the PAMA requirements. So it was a pretty rigorous application process. to become a qualified provider-led entity, and we are required every 5 years to go through a renewal of that QPLE status. And there are currently, I believe it's in the low 20s, 20 or so QPLEs that are listed on the CMS site. Next slide, please. We have a AUC Navigator, which is also available for anybody, and this includes the ACR guidance, our AUC documents, as well as the other documents from the other QPLEs. So this is just intended to give folks an opportunity if you want to take a look to see, well, what does the ACC have? What do some of the other QPLEs have as far as their AUC guidance? You can do that here. Next slide, please. So how are our AUC used in clinical decision support? So we have a licensing agreement with a company for the licensing and distribution of our AC content. And Care Select Imaging is that QCDSM, and Katie alluded to that earlier, one of the acronyms. That Care Select is that, and ACR Select is really a module of that Care Select product. And it's a digital representation of the ACR AC content. So they've taken the content that our expert panels have developed and distilled it in a way that can be integrated into EHRs and really digestible at the point of care. And we also, excuse me, we also have Care Select Imaging has a free portal available, which Katie alluded to as well. So for folks that may not have that ability to integrate into their EHR, there's a free portal that can be used. And the ACR is also going to be, in a few months, maybe a little sooner than that, have a portal available that can be used as kind of a supplement out there to what's available on Care Select Imaging. There's sometimes a little bit of a lag or a delay in getting the information integrated into their system. So the ACR portal will just show that the most recent content is available for everybody. So if folks want to consult that, they can use that as well, just as a supplement to the free portal that's available with Care Select. Next slide, please. That concludes my summary of the Appropriateness Criteria program. If you have any questions for us, you can email us, visit the website, give us a call. We are happy to answer any questions that you might have. So thank you.
All right, fantastic. Thank you so much, Christine. Really appreciate this great information. Before we move on, let's pause again, check in with Rhonda for any questions or comments in the queue before we move on.
I don't have any more questions, Michelle.
Okay. All right, we will move on to our final poll before we get to Dr. Capponi. All right, polling question number 5. Phil, will you please open our poll? Our final poll is one where you can check all that apply. The question is, which of the following are the biggest challenges, whether actual or perceived, to readiness? The cost of purchasing and implementing CDSM tools, time for providers and staff to learn and implement, buy-in of providers and staff, EHR and or billing software, or too early to say. So, Phil, what does our poll say?
46% said cost, 54% time, 61% buy-in of providers and staff, 21% EHR, and 32% too early to say.
Great. All right. Thank you very much, everyone. All right. We are pleased to turn the program over to Dr. Louis Capponi for a valuable perspective from the field. Dr. Capponi, the floor is yours.
Thank you very much, and thank you to my fellow panelists, Katie and Christine, for providing some really great background and for taking on the responsibility of talking through the regulations so that I don't have to, which is really delightful. I'm Louis Capponi. I'm a general internist by background, and I serve as the Chief Medical Informatics Officer at SCL Health. You know, the poll shows what would be expected in terms of a diversity of concerns, and I think we'll touch on many of them in the next presentation. So why don't we go to the first slide? So just a little bit about SCL Health. So we are a small integrated delivery system with hospitals in Colorado and Montana. SCL is the Sisters of Charity of Leavenworth in Leavenworth, Kansas, with a long legacy of providing health care. And in Kansas, we have 3 safety net clinics, which are a key part of our mission. We are a faith-based organization, and the 3 clinics listed there are entirely self-pay and subsidized by SCL Health. We have a lot of experience, and I'm happy to share that with you today. Next slide. And just, try to share some of the things that I've learned along the way during this journey. Here, I think I've outlined some of them for this talk, taking advantage of time and implementing early. So the federal government has given us a really important window of opportunity for action. And I think, as you'll see in the following slides, there really is a fairly long runway to get this implemented, particularly depending on where you're at technically. But as you'll see, I think also in the post-implementation period. A strong implementation team is going to be important. Communication is going to be key, because this is not a radiology department project, as much as it seems very radiology focused because of the billing and the technology involved. Really, the organizational change is at the ordering provider level, and that's where a lot of focus needs to come in, and communication is super important in working with those stakeholders. And then finally, in my estimation, about half the work begins after go live. And there's some things that you need to do, at least that we're doing, that I'll share with you to help with the adoption and I think with the overall success for the program. So next slide. So I mentioned that this is, much more change management than technology, and that's not to say that the technology part is not considerable, but it is fairly technical. The real change is going to come with interactions with your physician groups, the education and preparation of those groups for this change, and then the ongoing monitoring and feedback to clinicians around the program, how the program is evolving. I think, as was mentioned earlier, there's still some unknowns as to, what will be the impact in terms of variations of ordering on ordering providers. We certainly know that you won't be able to get paid for doing the study if the CDS wasn't recorded on your bill. There's less clarity as to how variations in ordering practices will impact the ordering physicians in the future. So a lot of things to consider as we're going along this journey. Next slide. So we set up a steering committee, which was fairly robust, and even I was surprised. I'm really a big fan of large steering committees, and in this organization, I hadn't seen as much of that when I first started, but I was pleased to see the number of people that are participating in this group. So we have stood up a decision support steering committee, which is really the governance for this implementation and program. It's actually co-chaired by the vice president who oversees the ancillary services for the organization, as well as one of our CMOs at the hospital who happens to be a radiologist, and was had an interest, and we needed to have some more care site based representation. But we had, as you can see, a lot of other folks. And if you go down sort of towards the bottom of the slide, I want to point out a couple of important ones. We have some joint ventures with radiology providers. And so it was really clear early on that we needed to bring them into this dialogue, because we were only, conducting part of the work, and some of the work, particularly the billing and some of our outpatient service providers, really needed to be connected to us so that we could make sure that the data flow was seamless between our organizations. and that they were not surprised when we were ready to turn on the system on the ordering side. And then finally, our vendor partner relationship was important, and the vendor has been joining our steering committee consistently, and that's also been extremely important because they bring, and your vendor will bring a lot of experience and help along the way. Next slide. So in terms of the goals, you know, we wanted to come at this from a clinical perspective. And so first and foremost, our goal was to assure that patients are receiving the most appropriate testing. It wasn't about revenue capture, although that was certainly important. It wasn't about the penalties that are coming down the line, although we did mention those, but really about how do you get the right care to the patient. And as Christine showed in the variant table, you know, there's some information around things like radiation exposure, and in our case also cost, that can be utilized as the physician is receiving this decision support in a way that's constructive and that you know, focuses really on the patient. The guidelines themselves, the fact that our guidelines are coming from the American College of Radiology proved to be extremely important in really getting physicians to focus. When we tell them we have guidelines that we've created, you know, across 8 hospitals, as you can imagine, and hundreds of practices, there's a lot of opinions. So the fact that we, you know, could go to a single source that was reputable and utilize those criteria was also extremely important. Next slide. So communication, as I mentioned, super important. We had actually a communication and change management plan. It was, I think it was 14 pages. Here's a little excerpt of it, which is the communication plan section. And we really identified a large number of stakeholder groups that needed communication, and we did a fair amount of it. We told people that things were going to happen. We told them why it was going to happen. We told them what was going to change. We told them when it was going to happen. We told them when it was happening, and we told them after it happened. And that was all very important because this journey is long. And as I mentioned earlier, it's not so much about the go live. It's really the work, as you'll see, that happens after the go live. Next slide. Created a number of different materials. We actually leveraged some of the American College of Radiology materials that they've produced around PAMA and the Appropriate Use Criteria program. We created elevator speeches and project goals and the usual things that you would see with a large-scale implementation. And then our communication to the medical staff was through multiple channels. I personally went out and spoke to all the medical executive committees to address the emergency departments and also the inpatient areas, because we implemented inpatient, even though that's not a technical requirement for the CMS. We felt that having a standard across the organization was important. And then I went out to our physician executive committees on the outpatient side, and we did a fair amount of communication through those medical leaders for about 6 months prior to go live. Next slide. Another very important stakeholder group that I want to call out, and it was alluded to in one of the questions earlier, is your external partners. Not only external imaging partners, but also the primary care physicians and specialty physicians in the community that may be referring into you. Those folks often are not focusing on regulatory changes, and many times are caught by surprise when they find out that their radiology studies won't be accepted if they haven't used a decision support tool. We have a large number of community-based providers who are private practices or group practices that refer into our radiology services. And so we had to do a lot of work, both educating them, and this is an updated education given that we have now additional time, plus leveraging and making changes to our portal to provide them with the ability to get access to the appropriate use criteria engine when they're sending us a study for to be performed. And so this external customer relationship was a big part of the work that we did in preparation, and it continues to be a big part of our closure of the technical part of this project as we get out to the community providers, educate them, update their portal access, and get them to send the orders to us along with the AUC codes that are necessary for us to bill for. Next slide. And so the technical part of the timeline, we started in January of 2019, so quite a while ago. Of course, we had a pandemic in the middle of this, so maybe it's not quite as long if you take out a few months, but there's still a fair amount of work that has to be done. Probably the biggest area of variation, and we have a single electronic medical record at our system, but we had grown organically over many years, and so our radiology orders were very inconsistent across different facilities. The naming was different, and so there's a fair amount of mapping and cleanup that we had to do. And so one thing I would advise is if you're you have an older install of your EMR or a diverse set of EMRs that you're going to be working with, work closely with your vendor to identify what pre-work needs to be done in terms of normalizing studies and that sort of thing, which will be necessary from a technical perspective. We went live almost a year ago now, and so really now is where the work is beginning. And so this is the technical piece, and in the next slide we'll transition into really sort of more of the change management aspect of this. Next slide. So as Christine mentioned, the variant table is represented here on the right of this picture, which is what the physician sees. Let me take you through the workflow. The physician orders a test and has to choose an indication. The indication defines an indication and obviously the order itself. So here there is an order for a CAT scan, and there's going to be an indication placed. When that order is submitted, a call goes out to a service for the decision support. And this is a really great example of what I would call good decision support because it does give information that allows for a provider to make a decision. It's not just a pop-up that says you did the wrong thing, but it says here you've ordered a test, it's scored as a 5. There's 3 other tests that are scoring higher and are more appropriate based on the ACR criteria. And then this is some information about radiation exposure and relative costs of tests. Now the doctor, again, doesn't have to take this, change their order, but they can easily do that here. And once this process is completed, then the regulatory requirement for using the appropriate use criteria have been met, and the order goes through. Next slide. So, the real challenge is with any of these implementations is getting the providers to utilize the technology. So there are 2 key metrics we're going to focus on, and we are focusing on now as we move forward. One is on the right-hand side, which is the unscored, and then on the left-hand side is the number of times when an order is placed that the provider is proceeding with something that is inappropriate. So the right-hand side really deals with the first PAMA or AUC requirement of using CDS, and we've got to get our providers to use CDS. And then the second one on the left-hand side is when they use it, how often are they proceeding with a study that is that's inappropriate. On the bottom, the ordering appropriateness rates are shown, and we'll cover that a little bit more if we have some time at the end. Next slide. So we looked at our data, and again, this is just 6 months of data, but we had some time to stabilize, and notwithstanding some changes with COVID-19, we looked at our use of the scores, and we found that in the ED, even though we were doing better than some benchmarks of other customers who use our EMR, we still weren't doing very well. And so we started to dig into this. And your first sort of hurdle is getting the docs to use it. You can't really go with a hard stop methodology, which is never very good because your inappropriate tests will go off the wall. What you want people to do is be engaged, and you also need to adjust the system to make sure that the right choices are there for the providers. And in the emergency department, where you have a lot of trauma and a lot of things going on, we had taken some time to try to sort through this. Next slide. And so the first thing was to go to the emergency room doctors and get some feedback. And that was a very robust discussion, and there was a lot of passion with some very good information. And I went to the directors of all the EDs. We talked to them. They gave the feedback. And so we started to dig in and try to find out what were the barriers that they were seeing to utilizing this. Next slide. Show some of the data analysis we did. We looked at what people were choosing when they were choosing something that was inappropriate. And then we analyzed this data. We worked closely with the vendor, and we updated the indications so that they really did match an ED workflow in a better way. And also that we looked at things that were where one option was green and another was red, and they're basically more of a technical issue than a clinical one. Just go ahead and fix those things. So we reduce and prevent the alerting at all. So just to go back, when we saw those order entry screens, if the provider has chosen an exam and a criteria that meets a green criteria, a green threshold, they don't get any alert at all. And that's really where we want to get people at. We want people to be choosing the right exam and using the right indication. The indications are also, we didn't have the ability when we started to save indications in favorites, so that if you're a trauma surgeon and you're always going to be doing a trauma series, which is appropriate, then let's go ahead and build that into an order set so that they don't have to go through the trouble of picking an exam for something that they're already doing another process for. We also allowed the yellows. So the appropriate use criteria, you just have to use the decision support. If you go to a green, you're getting the highest level. If you allow greens and yellows, you reduce some of the noise. Not too much. Most of it is pretty black and white, or green and red in this case, but there is some relief there. The other piece is the using a categorical indication doesn't allow for the clinician to necessarily explain more about the case. And what we're interested in is the use of natural language processing, so that instead of choosing neck trauma recent, we could look at the chart and glean from the chart what the indication is based on a bunch of clinical information. They're coming in for trauma, they have neck pain, and let the system do more of the work for the physician. And that should be something that is going to help with this adoption. Next slide. And we're coming up on the end of my time, but I did want to go through one last example. So not all changes for requests are what I would call appropriate. In the case of the trauma surgeon, where they're going to be doing a repeated trauma as part of an order set in the usual process, doing a pre-selection and reducing the number of choices that they have makes sense. But in this case, we got a request from one of our docs on the ambulatory side to change the lung cancer screening requirements, and just basically they wanted us to remove all the ones that were inappropriate. And when we looked at this, we can see, we looked at different practices on the right in this bottom right-hand box, and you can see there's a diversity of inappropriate ordering. Overall 6.2%, which is interesting because it's very similar to what we saw on the previous slide, but a lot of diversity. And what that said to me was that there's probably a lot of people who are ordering these exams incorrectly. Not just because they're choosing the wrong thing, but because they're actually are not adhering to the guidelines. And this, struck me as something that we probably shouldn't make a whole lot of changes here, because that's the point, is to try to get to more appropriate criteria. Here are the criteria for lung cancer screening from CMS in terms of eligibility. And now the work for us is to go back and dig into this data and identify who are the 10% of providers or the 12% of providers, or here the 25%. It's the small numbers, so that probably might be an outlier, but try to go deeper and see where do we intervene with education and with guidance to help those clinicians. Next slide. And then finally, governance. So you're going to have to govern this process over time as indications change or requests like the request I just shared with you come up. And we've incorporated that into an existing work stream of clinical content governance, where we oversee other types of alerts and or order sets and predictive models. Next slide. Okay, so that's what I had. I slightly over. Do we have time for any questions?
We do. Thank you, Dr. Capponi, and to all of our presenters. We truly appreciate your sharing your insights and expertise, and this is very helpful information for our Kansas healthcare delivery community. Let's check in with Rhonda, see if there are any questions or comments in the queue for our speakers.
Thank you, Michelle. I don't see any questions, but I do have a comment from Tish, who says critical access hospitals are exempt from the AUC. However, where I think there may be an issue is that if the physician employed by the CAH or the RHC orders the imaging to be performed in a facility that must report the AUC, it will be the ordering physician's responsibility to use the CDSM to get the AUC for the facility that performs the imaging to be able to be payment from Medicare.
Okay, thank you. And that's from Tish Hollingsworth at the Kansas Hospital Association. Thank you very much, Tish. So I'll pause there, and I guess that's all the questions we have for now. If there are any other questions that come to mind, please reach out to any of our presenters. Their emails have been provided in your handout. And we have just a few more moments, and so let's move on for just a wrap up. So we now invite you to participate in our very brief feedback survey. And Phil, if you haven't had a chance already, could you add the link in the chat? Simple to do, very helpful for us. You can respond anonymously or not. We'll share the summary of the feedback with our presenters, and we do hope to hear from you. We have a few upcoming events, resources that we can quickly share with you. For Kansas hospitals that use QHI for data submission and reports, you can attend a QHI training session tomorrow afternoon from 1:30 to 2:30, and the link to register is provided. And in case you missed it, we announced this on our last month's webinar. The 4th annual Kansas Opioid Conference is going virtual this year, and currently is accepting presentation proposals online through the end of this month. The annual conference will take place virtually the afternoon of November 12th and the morning of November 13th, and the link to more information is provided. And we're also very happy to announce our next month's webinar on September 23rd will feature Advanced Care Planning 101. This will be another special event with our healthcare partners in Kansas and Missouri with the Center for Medical Bioethics, the Kansas Foundation for Medical Care, HQI, and the Health Quality Innovation Network. And we invite everyone to join us for that. It may be the first of a series. And finally, if you're not already on our KHC Update email newsletter list, we invite you to sign up. Gosh, we made it right to the top of the hour. Thanks everyone for joining us. Thank you to our presenters, Christine, Katie, and Dr. Capponi. Again, we ask that you take a moment to respond to our short feedback survey, and if there are any questions you have, please type them into the chat and we'll be happy to follow up. And finally, please do not hesitate to reach out to any member of your KHC team for additional resources or assistance. Thanks again for joining us. This concludes our webinar, and we'll see you again next time. Bye-bye.